You're listening to the OCD Stories podcast, hosted by me, Stuart Ralph. The OCD Stories is a podcast dedicated to raising awareness and understanding around obsessive compulsive symptoms. I do this through interviewing inspired therapists, psychologists, and people who have experienced OCD. Welcome to the OCD Stories. And welcome to this special midweek episode of the podcast. And this episode is brought to you by the Neurobehavioral Institute in Florida. Now in this one, I got on Dr. Jonathan Hoffman and Dr. Dee Franklin, and we discuss whether eating disorders can be considered OCD. So in particular, we talk about what are eating disorders OCD, the overlapping criteria in the Diagnostical Statistical Manual for Mental Disorders, or the DSM for short. How does viewing eating disorders as OCD help with treatment? Avoidant restrictive food intake disorder, a fear of swallowing and choking, when emotional intensity feels too intense to do exposure and response prevention therapy, dealing with a harsh inner critic, and much, much more. I'm glad we got to cover this topic. Eating disorders is not something I've covered in a great deal on the podcast, although I have covered it before. And this is a new kind of take on eating disorders and OCD. And these midweek special episodes, which go out at the end of the month on a Wednesday, are made possible by and in partnership with the Neurobehavioral Institute in Florida, or NBI for short. I will be interviewing different members of their clinical team on a range of topics. NBI specialise in treatment and programs for anxiety, OCD, comorbidities, and complex cases. They also offer an intensive outpatient program and a residential program called the NBI Ranch, a supportive living experience that complements intensive treatment for anxiety and obsessive compulsive related disorders. To find out more about their intensive outpatient services or the NBI Ranch, as well as to read some of their free information online about OCD via their blog, visit nbiwestern.com. So thank you for NBI for making this extra episode possible. And of course, thank you to Dee and John for their time and expertise on this interesting look at eating disorders and OCD. And of course to you guys, thank you as always. I hope you like the extra content. And without further ado, here is Dee and John. Welcome to the show, Jonathan and Dee.
Thank you.
Yeah, it's good to have you. Yeah, it's good to have you both here. So Dee, this is your first time on the show, so it's great to meet you. And John, obviously you've been on before, so it's good to have you back on. So you both wrote an article recently on I think it was titled something like is eating disorders obsessive compulsive disorder or something like that. So I thought initially, obviously most of the people that listen to this podcast understand OCD and most likely have it. And many will also have an eating disorder too, I'm sure. But for those that aren't familiar with eating disorders, I'll just ask the question to both of you, kind of what is an eating disorder?
Why don't you take that? But before we start, I do want to mention our co-authors, Dr. Miriam Padron and Dr. Sienna Nicholas, as well, who contributed to the article.
Yeah, thank you.
Well, Stuart, you've asked the million-dollar question: what is an eating disorder? Because in the spirit of this talk today, maybe a little bit controversial, we're going to, motivate the hypothesis that ED is OCD. But maybe to back up a little bit, we should start by describing the present conceptualization, with them being somewhat related but different. And then through the course of our discussion today, we'll develop an alternative hypothesis, which is the reason that we wrote the article. So currently, I would say that eating disorders, there's a lot of different eating disorders and feeding disorders. And the current understanding is that it's an emotionally driven problem, that people can't or won't eat food because they can't deal with it emotionally. And I think the treatments are based in cognitive and behavioral therapy, a lot of the third wave therapies as well, including feminist approaches and relational approaches. But in a nutshell, it's problems with eating and feeding, and problems with coping with that emotionally. There's a whole set of compensatory behaviors as well that cause problems, mostly medically and physiologically. And yeah, it's a really, really unpleasant disorder to have.
And I think just to add one aspect of it, it's kind of the sense is that the problems with the relationship of oneself to oneself and oneself to society is being paralleled in the relationship with food.
Mm-hmm.
Because people are uncomfortable with themselves or uncomfortable with society, somehow what really needs to be done is they need to become comfortable with food and with their bodies.
Right.
And I think that's an important aspect of it also.
Yeah. So it's that idea of extreme emotional distress, like really strong emotions, and using a set of eating disorder behaviors to compensate, to circumvent the distress in some way.
Yeah, thank you for that introduction. And I guess as I ask this question, I hesitate a bit because maybe it conflicts with your article, which is how often do you see an eating disorder alongside OCD? If we just stick with the traditional view for a second.
John, can I go for this one?
Please do.
Okay. Almost all of our patients have some kind of eating issue. John, would you agree with that?
I would. And I think the reason that sometimes we don't think that way is because people who are treating OCD often aren't asking the questions and the people aren't volunteering, or some of them in the less glaring eating issues, as opposed to like the really obvious things like anorexia or things that you just can't miss. Some of the questions aren't being asked. And also sometimes there's these disordered eating aspects to OCD that are not being picked up, or not even being thought by the person coming for OCD treatment as to be relevant to their treatment.
Right. Yeah. Good point. My next question is kind of like, what questions do you ask in the intake that is revealing this stuff? Maybe that's a good question to ask.
Well, I have an activity that I do in all intakes, which is called a dietary recall. And what I'll typically ask the person in the intake is, can you tell me in as much detail as you can remember everything you ate and drank yesterday, just as an example, so that I could get an idea of what's typical, what's an everyday kind of eating and drinking pattern looking like. We might also ask questions like, do you find certain foods disgusting? Do you try to avoid certain categories or food groups? Do you have any other behaviors associated with eating that help you to modulate anxiety or discomfort? And it's also really important to ask people if they eat any non-edible items, non-food. Are there any other particles or substances going into their body that help them to feel relief or feel escape? That's also an interesting one to ask, and actually opens up a line of questioning for a whole nother set of psychopathology. So we have to ask that too.
Yeah,
and I think it's also just asking, just kind of frankly, you say you referred here for OCD treatment. Have you ever in your life, has anyone thought that you had an issue with eating? Has anyone in your family? And if they don't answer that, you could say, in your family history, has anyone had an eating disorder? Because sometimes people have an eating disorder and they just don't, or a dysorexia, an eating disorder that's just kind of a disordered relationship with food. And they're not recognizing that as, again, relevant to the discussion of why they're there now. So a lot of it is just making sure to cover, just like we would with anyone with OCD, even though they're coming from OCD, we would ask all the questions about OCD related conditions. And since OCD intermixes with almost all the time with comorbidities, we want to cover carefully each one. And in the last bunch of years, we've become even more cognizant of the importance of speaking about eating behaviors.
Yeah. And John, wouldn't you also agree that, sometimes leaving an open door in an intake or a clinical interview can lead to some important findings? So asking a question like, hey, do you have any eating habits that you think we should know about? As sometimes people will tell you about, compulsive gum chewing, or, all kinds of unusual behaviors or reporting sometimes come out. I'll ask the same question to the parents, and they are sometimes pretty good historians in terms of how behaviors have evolved over the years in their children. but it's really interesting to track unusual habits, selective or restrictive eating over the lifespan, and really see how the picture evolves.
And I think this is kind of the drawback if we're doing interview by questionnaire, because people will check no when it's really yes. And I think we do have to give that, using both very specific questions and, as Dee is saying, very open-ended questions, and really give it the time and due diligence it deserves in all of these areas, and not rush through it, because people don't report, won't report, don't think it's relevant for a whole host of reasons. But we all know with OCD that the errors are more of omission in interviews than commission. People may not tell you things, but if you ask and find a way that they have to kind of respond to it, that there's a kind of response that's being really specifically asked for, they're much more likely to tell you. So many people with OCD, whether it's eating related or not, they fail to reveal very relevant data. One, for fear it will be used against them in exposures. Two, maybe they won't understand. And, it's part of the OCD process. They are kind of somewhat, especially at the beginning of treatment, sort of aligned and used to protecting their OCD, and they sort of want treatment. And that ambivalence can be mirrored, of course, in the initial interviews.
Yeah. Brilliant. Yeah, I love those answers. So I'm going to quote a sentence from your article, because I think it maybe sums up what we're going to talk about nicely, which you say, we the authors agree and further argue from several perspectives that ED is fundamentally OCD with eating related symptoms. So yeah, that's my question, basically. Just what you want to say.
I think the issue that goes to the crux of the matter is OCD about content or is about process? If you're thinking about content, you certainly can make the argument that people with eating disorders and other forms of OCD think about things in a different way, may have on the surface different cognitive distortions, although when you boil it down, to me, they're all about the classic things of looking for guarantees and uncertainty intolerance and perfectionism and things like that. So if you look at it if you look at it from the process perspective, that the content doesn't matter, whether it's contamination or symmetry or morality or food, then the difference is really, in our opinion, and Dee can weigh in on this too. In our opinion, we don't see any differences when we really boil it down in that way and make that distinction again between process and content. But we see OCD as a process, not a content, which again brings up this issue about all the different forms of OCD. Is it really relationship OCD or sexual orientation OCD? Are these really distinctions without a difference? Or are these more relevant to maybe understanding and treatment than they are to conceptual understanding and mechanisms of action and explanatory concepts? But I think these are the really important matters to discuss at this stage of the evolution of understanding OCD and its treatment.
And we thought about this question really deeply. I think this is an idea that's not brand new. This is an idea that's been thought of by a couple of people in the past, but it's never really been taken very far. And when we first started discussing this, John, I think you and I started discussing it seriously probably in 2019, but you'd been thinking about it for a very long time. And we thought about deeply, well, what are the ways that ED and OCD are similar, but also what are the ways that they're different? And in the development of this article, we had to go and turn over every single stone that we could think of to try and prove and disprove our hypothesis. And I've got to tell you, and it's evident in the article, we really tried. And the closer we looked, the fewer differences we found. And then we looked closer until we really couldn't find any at all. And of course, the jury's still out, as they would say here in the States, right? The jury is still out. And we really want to stimulate discussion on this topic and hopefully gather some support and further interest in it.
Excellent. And how has it been maybe received by eating disorder professionals who maybe don't view it from an OCD framework. Yeah, how's it been received?
We recently, go ahead, John.
Well, I think the reception has been very interesting. I think people in the eating disorder community have been thinking about this issue as they become more cognizant of just how much OCD there is in their population or OCD adjacent issues and how relevant the techniques, especially exposure-based therapy, is to the treatment of eating disorders. I think, and from that standpoint, there's been a lot of kind of acceptance of it. But I think there's also a kind of this idea that, yes, all of those things are true, but people with eating disorders are different because they have to deal with a society that worships thinness, and they have to, and they're looking for their bodies to produce effects, and they don't, and their relationships are off, and food is a way of expressing the fact that they're not comfortable with themselves. They're not comfortable with their bodies. And I think from that standpoint, I think people still really have the idea that, yes, all of this is true, but there's a but there, and the but it's still different. But I like the quote, all new ideas are painful and need time to adjust to. And I think that's the situation we're in. Again, as Dee said quite rightly, we're not, obviously the last word on this, and research will bear it out and look for it. And there's certainly many questions around it. But I think it's very compelling about how, when you start to look at the DSM and just translate, they're in different chapters, but the different chapters are speaking different languages. And we found a common language to express eating disorders and OCD. We saw absolutely no difference.
Right. Yeah. As John likes to say, we feel like we're both building pyramids. So we're both speaking the same language here, the OCD community and the ED community. It's just a matter of bringing everyone together and trying to speak the same language. The reaction that I've enjoyed the most so far, since we've published the article and presented the idea a little bit, is sometimes we see our audience stopping and thinking and saying, wait a second, whoa, what? And the response has been very positive. And we've had responses from, wow, this is a big idea. I'm glad somebody's starting to talk about it in a serious way, all the way to kind of the head scratching response and people just taking a moment to wrap their head around this concept and kind of agreeing. It's fascinating, actually.
Yeah. And I think there's a little circular reasoning too. If they were the same, why are they in different chapters in DSM? And I think it brings up some of the issues with DSM that I think we all wrestle with in mental health community, that DSM is really not theoretical. It's descriptive, and it's not proscriptive of treatment. And it's a medical, it purports to be a medical model, but we're not talking about medical conditions. We're talking about mental health conditions, which have vast differences from medical conditions. And it brings up the issue of, by medicalizing these diagnoses and labels, are we doing a disservice to people by focusing on descriptive differences rather than, again, real explanatory concepts, real issues about functionality, the underlying concepts, the real explanatory concepts of psychopathology and its treatment.
Yeah, it's a good point. The DSM definitely has its issues, but it's useful, right? But it has its limitations. So it's knowing,
definitely a double-edged sword.
Exactly. Sure. Yeah. It's using it maybe with a pinch of salt at times. Yeah. So, but that also, I guess, what comes to my mind is OCD not being considered an anxiety disorder. Well, that was the change, wasn't it, when they took it out? What was it? Or yeah.
Yes, 2013. I guess, and the issue with that was that anxiety, of course, is a feature of OCD, but it's not the driving force of it. And OCD got its own chapter with OCD and related conditions in the present version of DSM and its present iterations. Yeah. And that was, I think, a step forward in evolution and understanding that there are conditions that are very similar to OCD. But I think that there's going to perhaps be some shifting of some other conditions that are very, very difficult to distinguish either in their mechanisms, neurobiology, and actually their treatment. So these distinctions become more like labels that are arbitrary rather than really speaking to what's happening. Because after all, OCD is a hypothetical construct. It's a way of describing things. People don't treat OCD. ERP isn't treating OCD. We're not treating an eating disorder per se. We're treating groups of symptoms which we're either lumping together or splitting and saying they're different enough that we have to think about them differently, or they're similar enough that we should think about them in the same way.
Really, really good point. And in your article, you guys do break out not all eating disorders, but I guess the more common ones against OCD, and you kind of show your workings about how they kind of relate or are very similar. So that's useful if anyone's interested, and I will link in the show notes. You do make the point in the article that you're not necessarily saying everyone with an eating disorder needs to do ERP, because each person is individual and maybe different therapies may be better. So I guess, anything you want to say on that before we,
I'm not sure we're saying that. I think exposure-based therapy is different than a lot of other therapies. One, because it's so supported by the research, but even more importantly, it has an active ingredient, because by creating an opposite action to where your mind and body want to take you, it actually is putting pressure on your whole system to change. Unlike some other forms of therapy, which are more speculative and insight oriented, which can be very useful in certain circumstances, but it's hard to argue that they have any active ingredient unless a behavioral change goes along with them. I think what we're saying is we don't think everyone with an eating disorder should run to an OCD clinic, because maybe they're better treated as long as they're getting treatment for their OCD. If their eating disorder is very severe, or they need refeeding, or they're in very bad medical straits, that would be the right place to do their treatment. I personally think it's kind of a shame that we segregate the world into eating disorder centers and OCD centers, because I think we have a toolkit, especially through cognitive behavioral therapy, that's an applicable toolkit to most human problems. And we just need to understand better about how to apply them better. And I don't think this obviates the issue that there is need for a comprehensive team, that just doing the psychological treatments is not going to be enough for OCD in many instances. It's not going to be enough for eating disorders. I mean, certainly people need medical treatments, they need family therapy, they may need interpersonal sorts of therapies. I mean, certainly clarifying values, a la ACT is very important, acceptance and commitment therapy. So I think it just really is important to us to broaden our understanding about all of this group of conditions, about what do we understand, and what's going to bring, as we said earlier, the most people, the best treatment, and the most efficient and effective way.
If you really think about the trends in eating disorder treatment over the past, let's say, 38 to 42 years, I think it had its roots in psychoanalysis and feminist perspectives, relational psychotherapy, and even the ED world has shifted over the course of the decades. Let's say the last 10 to 15 years has been really firmly rooted in cognitive and behavioral therapy, but it's kind of held on to its feminist and relational roots. And more recently, a lot of the leading eating disorder facilities are implementing exposure-based principles in their treatment and clinical models. And, so there is a lot of overlap now in the way eating disorders are being treated. And for sure, I think ERP is a really helpful intervention for your traditional eating disorders, because what is ERP about? It's about creating behavioral changes. And when you think about a traditional eating disorder or the traditional conceptualization of it, what are you trying to do? You're trying to change a bunch of really unhelpful behaviors and make that change sustainable, which is exactly what ERP is about.
Yeah, good point.
Interestingly enough, my partner, Dr. Katja Moritz, and I, we wrote an article about the use of ERP a long time ago, probably a couple of decades ago, and maybe it wasn't just a good article, but the idea was not well received. when we attempted to publish it. But as Dee said, we've been thinking about this for a very long time, and actually been treating eating as long as the medical situation is stable. We're not going to treat someone who's in such a bad way they need refeeding, or they're possibly going to have really severe physical damage or lethality from an eating disorder at our center. But we found that by using the toolkit that we have for OCD, can be very effective with eating disorders. But again, ERP is not a standalone treatment. It really has to do with a lot of the other issues. So you can bring in all those relational concepts and other concepts, and tailoring cognitive therapy to eating in some ways, and those particular issues. You can tailor the treatment to people where eating problems coexist or are completely overlapping with OCD.
Yeah.
I just want to come back to John's point about treating behaviors for a second, because I think this is really a pivotal point when we think about how these two problems and potentially other problems have so much overlap and imbrication in the behaviors and the symptoms. If we picture for a moment a compass point, so north, south, east, west, and we imagine maybe along north, south, compulsivity, impulsivity, and then we imagine east, west, harm, avoidance, sensation seeking, we can group a lot of different psychiatric conditions along these compass points. For instance, you've got your, eating disorders, body dysmorphia, maybe in one category, substance use, gambling, various addictions, trichotillomania, other behavioral problems. But if, including OCD, we want to kind of think about the behaviors and the intervention for the behaviors, the symptoms, as being somewhere along those continuums. And in many ways, there's so many similarities. And as long as we're focusing on targeting behaviors and changing behaviors, I think we're heading in the right direction.
Yeah, thank you both for those answers and the clarifications. I like that. You've kind of somewhat answered my next question, but I'll ask it anyway in case there's more detail, which was, how does viewing eating disorders through an OCD framework or as OCD help with the treatment of OCD, or improve the treatment of OCD? Improve the treatment of eating disorders?
Well, this is going outside our particular area of expertise, but when you review the literature, one wonders if the obsessions and compulsions with eating disorders are being treated the way you would treat obsessions and compulsions with OCD unrelated to eating disorders. So by looking at it through this lens, it may allow psychiatrists and other prescribers of medication to be focusing less on treating eating disorders and much more on what do they need to do to treat obsessions and compulsions and OCD related symptoms and rigidities medicinally more effectively. So surprisingly, that may not be done as much as when we reviewed the literature. It wasn't being done, at least in the research literature, as recommended as much as we might think.
And we consulted a lot on this issue. The gold standard for OCD treatments is obviously high dose SSRIs. But when we looked at the research for eating disorders, we found that was not the case. So if OCD and ED are to be viewed as similar, one might expect to see the use of high dose SSRIs being effective for eating disorders, but it's just not something that seems to be done. What we did find is that about 50% of guidelines for anorexia nervosa actually recommends a cautious use of antipsychotics, which is not typically recommended. That's contraindicated for OCD, the antipsychotic monotherapy. But on the other hand, if eating disorders didn't respond to high-dose SSRI, it doesn't mean that all of a sudden we've proved that they're different, because there's many OCD-related disorders that don't respond to high-dose SSRIs, like excoriation and trichotillomania. So I guess this is one of these areas that really needs some research and some maybe some clinical trials as well. The question is, will eating disorders respond favorably to high-dose SSRIs? Because if we see the same response that we see in most OCD cases, that could make a humongous difference for people suffering with eating disorders. Suddenly you've got a medication regimen that is a very big game changer. I mean, we've seen it, right, John, when our patients come into the clinic and they're not on the correct medications. When you put somebody on the correct dose of an SSRI, suddenly the OCD becomes so much more treatable.
And another reason for looking at this would be in treating people with eating disorders, it moves obsessions and compulsions to a very prominent place in the treatment plan, rather than they have an eating disorder and let's kind of on the side as an adjunctive kind of treatment, let's deal with OCD. It moves it to a position of prominence. And when we look at how much different symptoms explain the variance of eating disorders, I don't think we know the answer to this yet. But if it turns out that obsessions and compulsions and explain much more in terms of why people have eating disorders than some other speculations about what explains them, then that's a very important thing to understand, because it changes the foci of treatment.
Yeah, really good points. So what I'm going to do now is ask you a couple more maybe specific questions that may not entirely link into your article. However, if it does, please feel free to bring me back and us back to the article. So when I think about ARFID, the first time I came across that, my brain just went, that's OCD. That feels almost entirely like OCD, maybe more so than other eating disorders in my mind. So I guess maybe just to talk about that for a second, like what is ARFID and yeah.
John, let me?
Could you take that one?
Yeah, sure. So ARFID is avoidant restrictive food intake disorder, for those who don't know the acronym. And I think the history behind ARFID kind of answers our question and underlines your point really well. So ARFID was a disorder or a behavioral presentation that was first noted amongst autistic individuals years ago, before it was formally included in our current DSM. And as such, we should really look for the clues that ARFID originally gave us. ARFID is about selective eating, not based on traditional eating disorder thoughts about fatness, thinness, and body weight, shape, size. No, ARFID is actually based in disgust. It's based in textural, sensory. It's based in the sensorium. And so what we would see, particularly with autistic people, is that they would selectively restrict or avoid certain kinds of foods or food groups based on their propensity to feel disgusted, or based on their propensity to feel repulsed by a certain kind of food. More recently, I have noticed that ARFID unfortunately seems like it's a catch-all category. If diagnostically, sometimes I see that if a person's symptomatology doesn't neatly fit into some other eating disorder, but there's a bit of an avoidant flavor and there's a little bit of a restrictive flavor, people say, oh, okay, ARFID. But I think we do need to remember where its roots are when we're diagnosing people in the present. Now, we see ARFID a lot in our clinic. We see ARFID a ton in OCD populations, but I'll also point out that a lot of OCD patients may have autism as well. So we have this, a little bit of diagnostic sharing going on, and conceptually it makes a lot of sense.
And there's another issue that this sheds some light on. One of the criticisms or differentiating factors of proposing that OCD and eating disorders have a very high overlap, if not a total overlap, is that people, is it anxiety related, or is it fear related in terms of people are trying to avoid fear? So if we expand just like as in the OCD world, disgust has become an important and very relevant variable, that it's not always about fear or anxiety. Sometimes it's about a disgust reaction. I think that's what you see in eating disorders a lot, that it's that sure, it can be fear, but it could also in many cases be disgust oriented, that people are trying to avoid feeling disgusted. Because if we get to the idea that anything related to OCD, by definition, is a problem with experiential tolerance. So whether it's anxiety or incongruence with self-image, whatever it might be, including disgust, that's really where the action is. That experiential intolerance, that having some sort of faulty idea that your own inner experience should actually be under your control and match what you want it to match. And then because you find that aversive, trying to get out of that, change your experience through either rituals or avoidance or compulsions or things like that, that is the essence of OCD.
Hmm.
Yeah. And
because many people have this similar experiences, they just say, all right, I guess my mind is doing something today. They're not thinking they should control it. And that might be a very important differentiating factor, that box of experiential tolerance. We know in OCD treatment, building experiential tolerance is very important. I'm just saying that it has a high degree of conceptual theoretical relevance as well.
Hmm.
Yeah, I agree with you, John. I think that disgust is a huge component here, and probably needs a lot of further research, not only with OCD, but with eating disorders as well. And I'll also kind of add that disgust is unique from other emotional presentations in that it has its own very particular own behavioral components, physiological components, cognitive components. And I have recently seen some literature suggesting that people with OCD actually experience disgust at a much higher valency than a non-OCD population. And what we see every day in the clinic, Stuart, I'm sure you see the same, is that when disgust is a part of a person's OCD or eating disorder, disgust completely eclipses anxiety.
100%.
It's a much more potent emotional experience and therefore has the power to drive those compulsions and other compensatory behaviors, and it's very difficult to treat.
And one of the reasons for that is it's so visceral, and it seems so, we're often talking about fight or flight as a survival instinct, that disgust may be more salient and make you feel more like you have to do something about it than anxiety even.
Mm-hmm. Absolutely.
Yeah, that's a very good point. Yeah, disgust, 100% eclipse and trumps anxiety. And I guess that could maybe go for the other emotions like guilt as well. I see a lot with OCD, and that, again, they're not so worried about the anxiety. The guilt is the thing that they can't tolerate. The history was interesting as well. I didn't know that, where it came from.
I didn't mention, speaking about the history, one more thing about ARFID is that it's historically was a disorder of childhood, right? Which is that's a big change now. In the current iteration of the DSM, ARFID is across the lifespan, but that certainly wasn't where its roots were.
Yeah, interesting.
Mm.
Yeah, that is fascinating. So something else I wanted to bring up around food and maybe tied to OCD, although maybe not always tied to OCD, but this fear of swallowing. So when clients are just deeply afraid of swallowing, consuming food, and I guess anything you want to say on that, or I'll leave it open.
Yeah,
well,
go for it, John.
You please.
No, go for it. You go.
So, I mean, the first thing I'd want to say about that is that it's, for many people, it's fear of choking.
Yeah.
It's again, it gets into uncertainty. They're not sure if they're going to choke or not. I've had patients who have fear of swallowing because they think they're swallowing something they ought not to swallow. In some cases, it's been metal or wood. In some cases, it's an abhorrent object to them, or they got some contaminant or fluid they don't want to swallow or something like that, which has another connotation to them. Or I remember during the height of the AIDS epidemic in New York, a lot of people were afraid to swallow because what if they breathed in the air of somebody that they saw and triggered a fear that maybe they had, AIDS or something like that. And then they not only not swallow, they might spit. So we had an outbreak of people. I don't have epidemiological data on it, but there certainly were people that we would see in our clinic that were just kind of holding their breath, not wanting to swallow, and spitting because of a fear that was an OCD related kind of structure to it.
Yeah, when I see someone with a fear of swallowing, I'm either thinking exactly what John's thinking. Is this related to a fear of choking? Or the opposite, is it related to a fear of vomiting, which is also a different kind of phobia. But it all kind of stems back to, on the one hand, a catastrophic belief that something terrible is going to happen, either this way or that way, or a catastrophic revulsion or disgust about the sensation of certain foods in the mouth and what it feels like to swallow. Will it get stuck? Am I going to choke? Am I going to die? Am I going to vomit? And it's then really closely linked to really high anxiety and panic.
And it's also very interesting because what it has in common with all OCD kinds of issues is this idea that you're trying to control what are, pretty automatic bodily functions. We see this with people who try to control breathing, blinking, their thought process. Again, it's not so. It's more that people have this idea that they no longer trust their senses. I think we could say that that's a fair statement. They don't trust they're going to be alive in the morning if they close their eyes. They just don't trust reality anymore. And what's happening their subjective experience becomes more important to them, and their subjective experience becomes more important than the actual reality of life.
Mm-hmm.
Yeah, that's interesting. And just looking at my questions, so this came from a therapist I know who works a lot with eating disorders, and he said he wants to know about emotional intensity from an eating disorder, if we just keep it separate for a second, and when that makes it too intense to do ERP, how you sort of navigate that.
Okay. Well, let's picture for a moment some steps. Let's picture 3 steps. People with eating disorders tend to have an emotional dysregulation component as well. So maybe we lean on that idea for a moment. Emotional dysregulation is the experience of very strong emotions, very frequently, and sometimes occurring out of context, which you can imagine is a pretty miserable way to live your life. This constant, strong emotion, very frequent, sometimes surprising you. You can't predict when it's going to happen next. And so when, whether it's the OCD or the eating disorder, we really want to treat the emotion dysregulation first, because that's going to be a big barrier when you start ERP. So, with eating disorders, yes, there's a lot of emotion dysregulation. It's a problem of having an aversive reaction to your own emotional experiences. So, and I think the eating disorder conceptualizations would see it identically. So it's very complementary to the current treatment philosophies in eating disorder centers. John, would you answer the question similarly?
I would, to a large extent. I think I would add that people with OCD have emotional regulation issues too, and can get pretty upset and maybe are not quite ready for ERP. But I think the interesting thing to think about perhaps is that if you could somehow convince somebody to do the exposure at their height of not wanting to do it, it might be like that last rep in a push-up or weightlifting where you get the most effect. So my tactic with people is not to kind of treat them as fragile or and even look at the emotional regulation difficulty as a great escape and avoidance mechanism from doing anything in life, to help people understand the functionality of that and understand that they have a golden opportunity to make the most change possible in ERP if you're experiencing the most emotion possible. Now, is that true? I don't know. We is there really evidence that, if you do ERP when when it's hardest for you, it's better? I think maybe. But I think that's another interesting question that we can start to explore, again, as our evolution of understanding of treatment and the active ingredients in ERP starts to become more closely connected to neuroscience understandings.
Yeah, I like what you guys said. I listened to the episode with John and Katya that you did, and I like what came out of that episode because you guys ended up talking a lot about buzz phrases or taglines for OCD treatments. And one of my favorite ones you guys brought up in the last episode was, I can deal with this. I can cope with anything. And even if you are having a panic attack and we're doing this or that exposure, like, hey, you can do this. You can push through it. And maybe we find at the end of it that you coped quite well. Maybe you're still in a lot of pain. Maybe you really surprised yourself. But the point is that we don't know until we push it that way, until we, have the courage and move forward.
Really good points. Yeah, I love that. So this next question, I'm going to hesitate a bit as I ask it because I need to wrap my head around it because it's not something I've necessarily experienced with the young clients I work with. But again, the same therapist that asked this. So he's kind of noticed, and he said he's spoken to others that also seen it this way, which is when eating disorders are driven by a very harsh external critic that almost feels like it's its own external entity. And he said the people he's spoken to have all agreed it kind of feels like psychosis. It's of course not psychosis, but it has that kind of flavor to it of almost something, feels like something external is driving that eating disorder, like an external voice, I guess. Is that something you guys have noticed or?
Sure, and that can happen with OCD too, and that's I think that's some of the rationale for giving the OCD a name or treating it like a bully model. I think sometimes today we don't do that as much as saying, well, whatever's happening, accept it. So I guess you're walking around with a harsh critic. Again, going with the proposition that this is not psychosis per se, but just very, very strong overvalued ideation or very strong. That's how you started to label your discrepant thoughts as not me in some respect and working with that. That certainly can happen. But I think these things should not per se dissuade anybody from doing ERP. They just become, let's do ERP while in the presence of the harsh critic. And you can sort of build that into your treatment protocol, or you can actually role play it. You could say to somebody, hey, let's make a tape of a harsh critic. And while they're doing this, to touch something or eat a few food or whatever the case might be. So I think the important thing is to be creative and have a good alliance with the person you're working with so that you can work with all of these aspects and not see them as something which is precluding them getting the most effective treatment they can get, which is actually doing what they don't want to do. Yeah. And there's a host of reasons. And I want to mention, not to plug an article I just wrote, but I just wrote something about, for our website about the ways we cheat in ERP, which sounds very loaded and not fair. But I think I did not write saying I can't take it. A high degree of emotional regulation as an escape avoidance response. But now I'm going, since we can edit those articles, I'm going to include that because I think that's important.
Shameless plug.
yeah.
Shameless
I'll link
plug.
to it. Yeah. I'll add a link.
I'm actually reminded of I think an example that I encountered many, many years ago, much earlier in my career, treating eating disorders. I remember the case of a young woman who, I believe she was a gymnast or a dancer, I can't remember, but she recounted to me a story about how the coach, external, like let's get concrete for a second, the coach would make the athletes jump up and down, and anything, quote unquote, anything that jiggled needed to be lost. Right. So that's a pretty clear external message. But also, let's be frank, not every girl or boy in that line went on to develop anorexia nervosa. So for me, it comes back to whatever the external force is, even if it is concretely external or experientially external, it all comes back to an individual's own thoughts and their own predisposed, their own genetics, that they may be predisposed to developing a particular attachment or meaning to that kind of message and to their own thoughts. So,
and that gets to this crux of the matter, is that I think when we talk about eating disorders, there's often kind of saying, well, it's caused by society. It's caused by the treatment of women. Now, more men are having eating disorders, so it's just caused by this idealization of bodies. But the theory keeps changing. But we cannot get away from the fact that we are all exposed to the culture in some ways, more or less. Some people might have a parent or someone, or be more susceptible, biologically more susceptible, which I think is the core here. But the truth is, we are all exposed to these externalities one way or another, but only a certain percentage of people develop these conditions. So making an attribution that these conditions are caused by the externalities is very hard to accept just from a purely scientific perspective.
Yeah, really valid point. It reminds me of just OCD generally, like when cancel culture became a thing in the last few years, many people with OCD suddenly started worrying about getting cancelled, even if they weren't celebrities. They had that fear. Again, COVID happened. People are suddenly worried about COVID. So it's almost like the negative messages to girls and boys are just the trigger. They're not the cause, so like you said, there are people that see that all the time and aren't developing an eating disorder.
And I think that's one of the things that really is so important to pay attention to, is that we use the word trigger and cause as if they're the same words, but they're certainly not.
No, they're not. Yeah. Good point. So look, lastly, is there anything else you wish you could have said on this topic, or eating disorders, OCD generally?
Well, yes. Thank you so much for giving us the opportunity to speak about this topic, which we think is extremely important. The stakes are very high in eating disorders, as we know, because of the particular risks. That doesn't, I think sometimes we're confusing the apples and the oranges of whether OCD and eating disorders are the same, and conflating it with the risks of each. I mean, there are a lot of risks certainly in an OCD as well, but there are particular risks associated with eating disorders. But that really doesn't speak to whether they're different or not. But I think this is very, very important, because what we're really here to do is to try to help, again, as many people as we can. And I think having these discussions helps us move thought forward, treatment forward, and hopefully bring the separate communities. I've worked a lot with autism and OCD over the years, and I think those communities are closer together than they were not even that long ago, because I think that it's recognized that all conditions have overlapping features, and we're not in our different silos, and being in our different silos is actually detrimental to the mission that we have. So I really do appreciate, as always, the opportunity to speak on these issues on your program.
Thank you.
Yeah, definitely, Stuart. Thanks for having us. It's just such a privilege to speak about an idea that is very close to what we practice, and just raising the awareness, getting the message out there.
Yeah, absolutely. And thank you guys for coming on and sharing it. I'm always looking for different new ideas that may be moving things forward in a good direction. So thank you for sharing that with us. But yeah, thank you again. I appreciate it. Thank you for listening to this week's podcast. And thank you to our Patreons who helped make this episode possible. And if you would like to find out more about Patreon and the rewards and benefits, then there will be a link in the episode description. If you enjoy the OCD Stories podcast and would like to support us with a one-time tip/donation, please go to theocdstories.com/support. All tips, no matter how large or small, are greatly appreciated. Please subscribe and rate the show wherever you listen to the podcast. So thank you to NBI for supporting our work, and if you would like to find out more about their intensive outpatient services or the ranch, head to nbiwestern.com, or the link will be in the episode description. And quick disclaimer, guys, this podcast is not therapy. It is not a replacement for therapy. Please seek treatment from a trained professional. And until we speak, take care.